My name is Sean Wason, and I'm a faculty member in the Division of Urology at Beth Israel Deaconess Medical Center. I primarily work out of Milton and Needham hospitals, and I'm a part-time lecturer at Harvard Medical School. I was asked to give a talk on advances in the screening and diagnosis of prostate cancer. I have no disclosures related to this talk. We all may know someone that's been affected by prostate cancer. For me, it was my grandfather, Ernest Wason, who grew up in the sunny island of Barbados, the easternmost Caribbean island. I dedicate this talk to him. The objectives of my talk are to review the goals of screening. Who do we screen? When do we screen? How do we make the diagnosis? And how are we using imaging and biomarkers to screen our patients? Typical patient that may present to me in my office for prostate cancer screening. He's a middle-aged male. He has a strong family history of prostate cancer. Notably, his grandfather died of metastatic prostate cancer, and he has a brother who was recently diagnosed with localized prostate cancer and is undergoing treatment. He has no significant voiding symptoms. He feels well. He works out frequently. He does have well-controlled hypertension, and he takes medications for this and a statin for his elevated cholesterol. He drinks alcohol occasionally. He doesn't smoke. He's married, and his erections are normal. He was noted to have a relatively normal digital rectal exam that was round, smooth, slightly enlarged, but his PSA was 4.5 nanograms per milliliter. I like to review the prostate anatomy with patients. The prostate is typically the size of a walnut, measures about 30 grams, and is part of the urethral channel. It's tucked in between the bladder and the rectum, and the backside of the prostate can be palpated by performing a digital rectal exam. The function is a reproductive organ, and it contributes to semen. What we do know is that prostate cancer is common. It affects 1 in 8 men in the United States. If detected early, the 5-year survival rate is nearly 100%. The goals with prostate cancer screening are to minimize the detection of non-life-threatening cancers and maximize the detection of intermediate and high-grade cancers, as well as decrease the unneeded biopsies and treatment. As established by the American Urologic Association on the early detection of prostate cancer. What we mean by early detection is screening, and both imply detection of a disease at an early pre-symptomatic stage when a man would have no other reason to seek medical care. The panel recommends against PSA screening in men less than the age of 40. In this age group, there is a low prevalence of clinically detectable prostate cancer. The panel also does not recommend routine screening in men over the age of 70, unless they are in excellent health and they may benefit from screening. The panel strongly recommends shared decision-making for men in between the ages of 55 and 69 with either a primary care physician or urologist, and then proceeding with screening based on a man's values and preferences. How do we find prostate cancer? The two most common ways are a blood test measuring PSA or prostate-specific antigen, as well as a digital rectal exam. Screening is best performed when these two are taken in combination. Typically, PSA and digital rectal exam are done annually for screening, but this does not tell you if someone has prostate cancer. You need a prostate biopsy in order to make the diagnosis. PSA stands for prostatic-specific antigen. It's a protein in the semen that liquefies the ejaculate. It circulates in the blood of all men with intact prostates. The good news is PSA is only made by the prostate. However, prostate levels can be elevated for several reasons, such as inflammation, trauma, or natural enlargement as men age. I think a lot of men need to know, what is your PSA and what is the trend? What is the velocity? How quickly is it rising? It's one of the earliest known biomarkers used in urology. It's used in several phases of the disease, including screening, diagnosis, after local treatment, in advanced as well as metastatic disease. In regards to PSA screening, from a urologist's perspective, most would agree that mass screening is in the past. PSA does have several limitations. It's not a definitive test for prostate cancer. Shared decision-making is important. High-risk patients, such as those with first-degree relatives and family members, should be considered for screening. Age and comorbidities will often dictate who gets screened, which is also dictated by primary care providers, Who gets biopsied and diagnosed is often dictated by urologists. The National Comprehensive Cancer Center also has their guidelines on the early detection of prostate cancer. If a PSA is less than 1 nanogram per milliliter and there is a normal digital rectal exam, repeat testing can occur at longer intervals. If a PSA is in between 1 and 3 with a normal digital rectal exam, repeat testing should occur at 1 to 2 year intervals. If a PSA is greater than 3 or there's a suspicious nodule on digital rectal exam, the PSA should be repeated and this patient referred for possible biopsy. In these patients, we would consider the use of multiparametric MRI as well as biomarkers. If there remains a high suspicion for prostate cancer, these patients should undergo prostate needle biopsy. If there's a low suspicion for prostate cancer, the PSA and digital rectal exam can be repeated at a shorter interval. In my practice, I often use transabdominal ultrasounds to determine the size of the patient's prostate. By taking the PSA divided by the prostate size, we can determine the PSA density. The denser the prostate is, the more concern there is for prostate cancer. Biomarkers available for risk stratification in patients with suspected or known prostate cancer. Biomarkers are biologic molecules typically found in blood, urine, or tissue that can be used as a marker of normal or abnormal processes within the body. Biomarkers can be used in all aspects of patient care. It can be done before a biopsy, prior to repeat prostate biopsy, after biopsy, or post-treatment. Biomarkers should, however, not be routinely used in all patients. I use SelectMDx, which is a urine-based biomarker in my practice. I will use this for patients that have had a negative prostate biopsy in the past. Those patients with a very large prostate with a smaller concern for prostate cancer, and those patients that may be in the gray zone or hesitant to proceed with prostate biopsy. The assay looks for 2 genes, HOXC6 and DLX1, that have been shown to be associated with prostate cancer. Findings associated with the digital rectal exam, the PSA, the patient's age, and the prostate size are combined into a report that tells us the likelihood of finding prostate cancer upon biopsy, as well as, more importantly, the likelihood of detecting a clinically significant prostate cancer, which is considered a Gleason 7 or greater. I will also typically use multiparametric MRI frequently in my practice. In patients considering a prostate biopsy, all patients will undergo a multiparametric MRI, which stands for magnetic resonance imaging. There are several sequences performed in the MRI, and we can evaluate the MRI for suspicious areas within the prostate if there is evidence of extracapsular extension, seminal vesicle involvement, lymph node involvement, or possible bony metastasis. The radiologist will give us a score, PI-RADS score, from 1 to 5. And I think it's extremely important for men to know, what does my MRI show? Does it show any PI-RADS 4 or 5 lesions? And where are the lesions? Another imaging modality that is currently being employed is microultrasound. This is a high-resolution ultrasound probe that provides real-time images similar to a standard transrectal ultrasound. This can be used in both the initial biopsy phase and the surveillance phase on patients diagnosed with prostate cancer. The images provided by microultrasound are far superior and can provide detailed local anatomy. It also has a very similar scoring system to the PI-RADS system called Primus. The higher the number on the Primus score, the higher likelihood of finding clinically significant prostate cancer. Prostate biopsy is typically performed transrectally, and the goal is to sample the peripheral zone of the prostate. On average, 12 cores are taken, 6 on either side, in the peripheral zone of the prostate. The prostate biopsy will tell us, is there prostate cancer or not? What is the Gleason grade, which is the aggressiveness of the prostate cancer? Gleason 6 prostate cancers are the least aggressive, whereas Gleason 10 prostate cancers are the most aggressive. The prostate biopsy also estimates the volume of the cancer, the number of cores involved, what is the location, and if there is perineural invasion, which is a poor prognostic indicator. There are 2 standard ways to perform a prostate biopsy. One is via the transperineal, and the other is via the transrectal route. Both are typically performed in the office, under ultrasound guidance, by a urologist. The added benefit of performing the transperineal biopsy is that anterior aspect of the prostate is more easily sampled. There may also be a slight decrease in the risk of infection via the transperineal route, although recent data is questioning this. Multiparametric MRI ultrasound fusion is a technique used to sample lesions noted on MRI. After the MRI is complete, the radiologist will encircle the lesion on the MRI, and then these images can be fused in real time to a standard transrectal or perineal ultrasound to ensure that the lesions that are noted on MRI are sampled. As prostate cancer can be found 15 to 20% of the time in other areas of the prostate without a lesion, usually the fusion-guided biopsy are also performed with the standard 12-core needle biopsy. After the prostate is sampled, the cores are all sent to a pathologist for evaluation and are given a Gleason grade, which ranges from 6 to 10, 10 being more aggressive. Patient needs to know, what is my current Gleason score? Once we know the Gleason score, the number of cores involved, the PSA, the digital rectal exam finding, the patients are given a risk category ranging from very low, low, intermediate, high, and very high risk. This will determine the extent at which imaging studies need to be performed for evaluation of disease outside of the prostate. In patients with low and favorable intermediate risk disease, genomic biomarkers can be performed on tissue removed at the time of biopsy. This will determine the biologic aggressiveness of the prostate cancer. This is useful for patients considering active surveillance. In patients found to have unfavorable intermediate risk, high risk, and very high risk disease should undergo additional imaging to ensure that there's no metastatic disease or disease outside of the prostate. Traditional imaging includes CT scan of the abdomen and pelvis, as well as a bone scan. Although CT and bone scan are still widely being used for imaging, slowly this is being supplanted by a more sensitive test called PSMA PET scan. PSMA stands for prostate-specific membrane antigen. This is a protein found on the surface of most prostate cancer cells. A radio-labeled pharmaceutical agent is tagged to PSMA. The whole body is scanned, and this will easily identify areas outside of the prostate where there may be prostate cancer metastasis. After a diagnosis of prostate cancer, many men will ask, how can I be proactive in my fight against prostate cancer? One of the fathers of prostate cancer treatment is Professor Laurie Klotz from the University of Toronto. He recommends smoking cessation, consider a low-dose statin, vitamin D supplementation, as well as metformin. In summary, prostate cancer is common and its aggressiveness is quite variable. Earlier detection is favorable and can lead to a cure a lot of the time. Our goal with prostate cancer screening is to maximize detection of intermediate, high, and lethal cancers, minimize the detection of non-life-threatening cancers. We can do this with improved imaging and genomics, which can improve risk stratification. This has also allowed urologists and patients to be more comfortable with active surveillance. Thank you for your attention.